This conference will now be recorded.
Good morning, everyone. The previous two classes we have discussed about seen the presentations on acute pancreatitis as well as alcoholic liver disease. These both are very useful for you in the final semester, that is in the exam going batches, ninth semester. So you should know the just only the basic things or just about both the topics. I discussed previously acute pancreatitis and alcoholic liver disease. Both are essay questions for you. Today we'll be seeing the same presentation on Gastro Esophageal Reflux. This is an important 4 marks question in the final examinations in the ninth semester. That is exam going back in the final year. So kindly listen to the seminar for 40 minutes. I'll be simplifying the topic. Try to simplify this topic and we'll see. So today's outline of the presentation is we'll seeing all the topics in the following discussion, like definition of the GRD. What is the pathophysiology of gastroesophageal reflux disease? You will see the clinical manifestation, how it manifests, and how to evaluate the case, that is come to the diagnosis, and what are the treatment and what are the complications. So firstly, we'll see the definition of GRD. So various definitions were there, but according to the Montreal Consensus Panel, that is for 44 experts, have described it like this: a condition which develops when the reflux of stomach contents causes troublesome symptoms or complications. See these lines means what it exactly explains means it is telling that everyone will be having this reflux of stomach contents, but only some people will be having the symptoms, or they may have the some troublesome symptoms. So only in that cases only we will be telling the describing it as gastroesophageal reflux disease only when the patient or the person develops troublesome symptoms. So in the coming slides, we will see what are these troublesome symptoms and what are the complications. So how will we how will be treating? Because why I have chosen this topic is not only a 4 marks question, but also as we according to in our food habits. So mostly nowadays we are eating much more like junk foods, like containing the more fat content foods rather than dietary fiber foods. So that's why what happening is this GRD is most common. That too nowadays. Previously it was around 60-year-old male patients or 50-year-old like obese people or fat people. Only in these people we used to see this GRD, but nowadays it's will become more common as well as in younger population also, not only in the older age group but also in the younger population. This GRD is becoming more common. So coming to the this topic in proper. So what are these troublesome means? What is the troublesome means? Patient gets to decide when the reflex interferes with the lifestyles. Means, see, you can see here, this patient complaints. Everyone will be having this reflex of stomach contents. So in some people there may be asymptomatic, means this reflex may not cause what are this reflex of stomach content reflexes means whatever the HCl that is produced within the stomach because of this regurgitation, that is through the relaxation of the lower esophageal sphincter, this acid content reflexes will regurgitate into the lower esophagus. So as a result, what happens, these are reflexes which contain consisting of this pepsinogen. This damages the mucosa of the esophagus. As a result, it leads into the necrosis. So this is the main pathogenesis involving in GRD. So as a result, what happens means the patient will complain of chest pain. Since actually here the pain is due to the damage of the lower esophageal sphincter as well as the lower part of the esophagus. So here the patient complains of heartburn, or also maybe complaining of dysphagia, odynophagia, or he may be complaining of chest discomfort as well as chest pain. So these are the troublesome means here the troublesome symptoms means this. What I explained here is that these are the troublesome symptoms. So now coming to the definition according to the American College of Gastroenterology, symptoms are mucosal damage produced by the abnormal reflux of gastric contents into the esophagus, often chronic and relapsing, and may associated with the complications of GERD in patients who lack typical symptoms. So this is according to the definition of American Gastroenterology. Coming to the, so here GERD may be physiology, as I mentioned earlier. If the patient is not having any symptoms or he may be asymptomatic, so that is in normal people also there will be reflex of content. So that is physiology GERD. And what the patient becomes that trouble, the main word troublesome means that, as I mentioned earlier, that dysphagia, odonophagia, chest discomfort, heartburn, all these complaints will come under the troublesome symptoms. So if the patient is having troublesome symptoms, then he is maybe pathologic GERD. So in the pathologic GERD, the more pathology itself means there may be damage to the mucosal integrity. So if there is this is histological. Purely we will be seeing, we will be along with the symptoms. If you go through the histopathology, if you go to see the histopathology, there will be a mucosal damage. So mucosal integrity will be lost, and there further because of the action of the pepsinogen or the mucosa, there will be necrosis. So this is pathological GERD, and so how will be differentiating whether the patient of GERD is a physiological GERD or a pathological? To see these important differences. So usually physiological GERD usually is seen after post-prandial, that is after the consumption of food. We will be seeing this, and it is very short-lived. So and it also be asymptomatic, and nocturnal symptoms are not seen. So whereas when compared with the pathologic GERD, we can see the symptoms, but it may be pre-prandial or post-prandial, the symptoms will be persist. And also there will, as I mentioned earlier, there will be a mucosal injury and nocturnal symptoms. This is very, very important, because this is the way we'll be differentiating between physiological and pathological. As I mentioned earlier, everyone will be having this GERD. Some people may be having some intake of spicy foods. There may be some aggravation, but within the pathological condition, whether we consume the food or not, in this patient there will be symptoms. There will be persistent symptoms, and also there will be, if you see the integrity of the mucosa, there will be damage to the mucosa, and then further leading into the necrosis. And also these patients will be having nocturnal symptoms. Why these nocturnal symptoms is significant? Because typically these patients, how will we actually, we should know how these GERD patients, because many of the people are having these illness. And if we go to the medicine OPD, you will see out of out of the 50 patients are having the OPD patient, 20 people will be giving all these symptoms along with their other complaints. So that much important is GERD, because most of the people, according to the Indian food habits, almost majority of the people are having these symptoms. So what are these nocturnal symptoms? How they have effect on the patient? See, nocturnal symptom means as soon as the patient lies, what happens is on the supine portion, these reflux of gastric contents become easy. So the what happens is these contents which are within the stomach, these acid reflux contents, they get regurgitated into the lower esophagus. From there, we will be seeing that the esophagus and the trachea are approximately, they will be closely approximate. So what happens is whatever these regurgitant content, they reach the upper esophagus, and as a result there will be micro aspiration. So what happens is this, because of this micro aspirations, these contents, acid content, slowly reaches the pulmonary alveoli. As a result, damages the alveoli, and the patient will be presenting in the nocturnal cough. This is the main reason. So further in the long-standing cases, if the patient left untreated, what happens is this, because of this high aspiration of these contents, the patient will develop aspiration pneumonia. So this is one of the dreadful complication in the case of GERD if it's left untreated, or if we may not, if we didn't modify his life habits. So this is very, very important. So why GERD is significant? It may directly it may not cause any death, but it becomes these extra esophageal symptoms, like say what cough, nocturnal cough. If you go through thoroughly, if you see the patient, he may develop aspiration pneumonia and any interstitial lung diseases, and also then chronic bronchitis. What happens is in this patient, in chronic bronchitis patient, these patients will be presenting with the nocturnal cough and persistent cough for months. There's a period of for if you take a 1 year period, 12 months, these patients will be having chronic cough that for about 3 months. If we suspect tuberculosis, if we go for MTB, that is tuberculin test, this patient shows negative. So see how these GERD patients may land into the aspiration pneumonia and chronic bronchitis. So see here the lower esophageal sphincter. So what is how this integrity of the lower esophageal sphincter is maintained means, so in general the esophageal lower esophageal sphincter and the crural of the diaphragm, these both together form the integrity of this barrier. So if this barrier is normal, what happens is this after the consumption of food or in normal conditions, these acid reflux contents are not allowed to pass into the lower esophagus, because in case of well integrated lower esophageal sphincter as well as the crux of the diaphragm. So these are the both, that is lower esophageal sphincter. I repeat, this lower esophageal sphincter and the crux of the diaphragm, these maintain the integrity of this barrier. As long as these both are in integrated, that is in a normal this GRD does not occur. But once if there is incompetence or if there is any relaxation of the lower esophageal sphincter or the integrity is lost, then the patient develops GRD. So there may be so many reasons for this loss of the integrity or the incompetence. For example, if we see the example, say alcohol, caffeine, that is coffee, or any tea or any spicy foods. So these are any chocolates or any peppermint. These what happens is these causes the relaxation of the lower esophageal sphincter. So because of this relaxation, what happens is this reflex contents regurgitate into the lower esophagus. So these may be physiological as well as pathological. So physiology means if the patient if he starts decreasing the intake of coffee, or also if we decrease the intake of chocolates, or if we decrease the intake of tea, or if we decrease the intake of alcohol, these symptoms get resolved. So that itself signifies that this may be the physiological GRD. So in after this decreased intake of all the above food items what I have mentioned earlier, in that case also if the patient have persistent symptoms, then we should think of pathological GRD. So what are the causes? Some of the causes of pathological GRD. So pathological GRD may be esophagitis. Esophagitis may cause, or the lack of integrity of the lower esophageal sphincter, any hiatus hernia. All these conditions, or any peptic ulcer disease. All these conditions may develop pathological GRD. So see here we can say the intrinsic distal esophageal muscles tonically contracted. These muscle string fibers of the gastric cardia, diaphragmatic crura, transmitted pressure of the abdominal cavity. See, these distal esophageal muscles and the diaphragmatic crura together form the integrity of the lower esophageal sphincter and maintain the position. So here we can see this angle because of this tenting or the kinking nature. That's why these regurgitated, what are the acid contents that are present within the stomach, these are not regurgitated directly. So you can see here, because of this kinking nature, this kinking nature is maintained because of the, here we will be seeing the surrounding diaphragm. So because of this diaphragm and this lower esophageal sense contractility or the tonic nature, this makes the integrity strong, so that these reflexes are not regurgitated into the lower esophagus. So coming to the pathophysiology in proper, the primary barrier to the gastroesophageal reflux is the lower esophageal sphincter, as I mentioned earlier. So this lower esophageal sphincter normally works in conjunction with the diaphragm. If the barrier gets disrupted, acid goes from the stomach to stomach. This stomach to esophagus. This is self-explainable. So see, this is a my important slide. So entire pathophysiology of it, how it develops, how it leads to the symptoms, that is esophageal symptoms as well as gastroesophageal symptoms. You can see in this here. See, if there is any impaired clearance. So what are the conditions that may lead to the development of GRD means, if there is impaired clearance. So whatever the contents, your esophagus as well as the stomach will be producing this. If the contents gets pulled up, this may lead to the GRD. Another is, as I mentioned, is a pathological cause, that is hiatus hernia. This herniation of the esophageal stomach gastric contents into the esophagus, that is hiatus hernia. This patient will be present with abdominal pain, very severe abdominal pain. In this case, the patient will be presenting, and also the transient inappropriate relaxations of lower esophagus. Because of the inappropriate nature, what happens is after the relaxation, this patient, lower esophageal sphincter, if it does not close normally, it does not reach to its normal position. What happens? The gastric contents will be getting regurgitated into the esophagus. And another is higher excess production of gastric acid, that is pepsin secretion. In case of raised pepsin secretion, what is the significance of this pepsin? What I mentioned, see this pepsin acid, which is inactive form of pepsin. This inactive form pepsinogen is converted into pepsin. As a result, what happens is this damages the esophageal mucosal integrity. or it damages the mucus directly, leading to the necrosis. So this is one of the important pathophysiology in the case of GERD. Another is pyloric sphincter duodeноgastric reflux. This may also cause the GERD. This indirectly causes, not directly, but it indirectly causes the. Another is impaired salivary function. What is it? What is the role of the salivary glands function? Because what happens is the stomach gastric contents are acidic in nature. But what happens? What is the content of salivary gland? Along saliva, the saliva is rich in bicarbonate. So bicarbonate itself, it's in alkaline. So what happens is if the gland secretion decreases or there is impaired salivary gland function, this, as a result, the saliva content decreases. If the saliva content decreases, what happens? Similarly, bicarbonate proportionately, bicarbonate also gets decreases. So there will be decreased neutralization. That is, this alkali. What alkali is? Bicarbonate. If the content decreases, these neutralization decreases. So as a result, the gastric nature, this is acidic nature in the lower esophagus increases, further leading to the damage to the mucosa. So that is how this impaired cerebral gland function is a it has a role in the pathophysiology of GERD. And the next one is an impaired esophageal mucosal defense and reduced resting pressure of the lower C. What is resting pressure means? Resting pressure means the pressure within the lower esophageal sphincter where the tone or the contractility of the lower esophageal sphincter is maintained. So as a result, this regurgitation does not occur. So that is a resting pressure. If this resting pressure decreases or the intragastric pressure increases, this leads to the regurgitation. So another one is the delayed emptying. So what happens in case of delayed emptying? If there is delayed emptying means there will be pulling up all the secretions. So once the pulling up of all the secretions occur, the pressure within the gastric funda or the gastric increases. This is further leading to the relaxation of the sphincter. So this is the pathophysiology in detail, or in single slide you can note it out. So as I mentioned earlier, that is GERD, pathological GERD, hiatal hernia is one of the one of the cause of pathological GERD. So what happens in hiatus hernia? See here, the lower esophageal sphincter pressure is often low. So gastric pouch or the intrathoracic gastric pouch, intrathoracic reservoir, diaphragm, no esophageal space. What happens means this gastric content or the gastric part or the stomach wall, this gets, because of this laxity or the decreased laxity in the lower esophageal sphincter, if there is incompetence, what happens is this gastric part, that may be funda region, and this part of the stomach gets herniated or gets herniated into the esophagus. So this leads to there will be impaired whatever I have mentioned earlier. See, there will be impaired esophageal clearance. So as the result of the impaired esophageal clearance, these stomach contents gets regurgitated, as well as because of the incompetence of the lower esophageal sphincter, these stomach contents gets regurgitated. So these get pulled up within the lower esophagus, and this causes the mucosal integrity damage. So this is the way how hiatus hernia that causes GERD symptoms. So here we can see this is entire, this is the herniated part of the stomach wall. This is the herniated part. You can see. So as I mentioned earlier, there may be symptoms. The there will be the symptoms of GERD, that is esophageal symptoms or extraesophageal symptoms. So what are the esophageal symptoms? How will the patient presenting in the OPD or in the casualty? See, here the patient says severe heartburn, dysphagia, odynophagia, regurgitation, belchings. These are the characteristic features in case of esophageal. See, here will patient in some patients, in some patient that is elderly, 40 years old above. So what happens in the general OPD? What kind of cases we'll be seeing with? See, this heartburn patient generally above 40 years, they will be complaining coming to the OPD and saying, sir, I am having severe heartburn, and especially in the early morning or also night before going to sleep. I am having very severe heartburns or also chest discomfort, and they will be giving the history, sir, where I'm diabetic as well as hypertension. So what will be misleading in this case means generally post 40 years, if he is a diabetic, if he's not having any well proper control of the sugars, what happens means in these patients, because these patients may be having some silent MS. So similarly, MI patient also present to the casualty with heartburn or radiating the pain to the back of the chest. There may not be radiation. May not be radiation. Classically, MI patient maybe, if you see the MI patient means they should have chest pain, or you should, the pain should be radiating to the left shoulder. That may not, in some patients, there may not be that classical symptoms. In case of diabetics, that too, in the case of improperly controlled sugars, what happens is these patients may be presenting to us in the form of silent MS. Silent MS means, what is the silent MS means? What happens is, in case of uncontrolled sugars, because of the autonomic neuropathy, what happens is the patient may not know the senses. So you will be seeing in the old age people, or in maybe you will be seeing in grandparents if they're diabetics. You will notice, if you ask them, they will tell you that I'm not able to feel the senses in the lower limbs. I'm having tingling sensation. I'm having numbness. So these are the features of neuropathy. So similarly, autonomic neuropathy also may be seen in case of uncontrolled diabetics. So that patients may not give the classical chest pain. So they will come to the casualty like with similar features like heartburn. And here we can see the dysphagia. Why this dysphagia occurs means, so because of this lower esophageal integrity is not maintained, these patients will be presenting with this dysphagia and also the damage to the mucosal integrity of the lower esophagus. This patient may be presenting with odynophagia. What is dysphagia? Unable to swallow the food. What in case of odynophagia, there will be painful swallowing. What is this regurgitation? As I mentioned, the regurgitation, belchings. These are the 5 characteristic esophageal symptoms of GERD. So now coming to the extra esophageal symptoms. What are these extra esophageal symptoms? Cough, wheezing, hoarseness, sore throat, globus sensation, epigastric pain, non-cardiac chest pain. So see the non-cardiac chest pain, because the cause of this chest pain is not MI or any within the pathology within the heart. This is because of the esophageal integrity damage. The patient may be experiencing the heartburn, epigastric pain, as well as the non-cardiac chest pain. So why this cough occurs in this case of GERD patient means, as I mentioned earlier, nocturnal cough is a characteristic in these patients. So why the nocturnal cough occurs? Because, so this is again for revision for the people who are not present in the earlier 10 minutes. So what happens, what is this nocturnal cough, how it is occurring nocturnal cough in case of GERD? As I mentioned, so after the supine position, after the taking sleep, after going into the bed, the patient will be on supine position. So what happens, these gastric contents, because of the decreased integrity of the lower esophageal sphincter, these stomach reflux contents gets regurgitated into the lower esophagus. From the lower esophagus, they get into the middle and the upper esophagus. From there, there will be aspiration of these contents into the trachea. Through the trachea, they will be reaching into the pulmonary alveoli. So here, this patient may be develop aspiration pneumonia. So anything other than air, if any particle or contents, as we all know, if they enter into the trachea, will be having a protective cough reflex. So that's how this patient will be presented with nocturnal cough. What happens if these regurgitant contents it gets accumulated within the trachea or the alveoli? So consider these are as the foreign particles. If these foreign particles enters into the alveoli, what happens? There will be, as soon as the protective reflex, that is cough reflex, gets stimulated. So we'll be having dry cough. So if there is per se damage within the alveoli or the parenchyma of the lung, if there is any infection or the inflammation, then we'll be having the productive cough. So remember this word. These patients will be having non-productive cough. Why non-productive cough? Because there is per se, there is no damage within the lung parenchyma. This is because of the defect within the lower esophageal sphincter and the lower esophagus. These refluxed or regurgitated contents acts as a foreign particle and they enter within the alveoli or the trachea and they cause irritation to the alveoli. As a result, there may be or trachea, there will be non-productive cough, that is dry cough. So here see, you can see this pictorial representation. This image describing about in case how the GERD patient will be experiencing this. See the heartburn, gastric burn. There will be epigastric discomfort or any regurgitation can because of the heartburn. There is non-cardiac chest pain, everything. So coming to the symptoms, how the patient in a decreasing order, how the most common complaint they will GERD patients will be presenting next followed by the, you should know this, right? Because you will be seeing the number of cases as you after completion of your majority of the patients you will be seeing coming to the casualty or the cardiology OPD also. If the patient presenting I am having chest pain, first you have to rule out by taking ECG we will be ruling out the MI. So next immediate cause is GERD or any acid peptic disease. So the first complaint, that is predominant complaint in the GERD is heartburn. That is, see here the predominance is 80%. Next followed by the regurgitation, that is 54%. And abdominal pain, you can see 29%. Next followed by cough, 27%. That to the nocturnal cough most commonly. And dysphagia for solids, 23%. Next is hoarseness, 21%. Belchings, or 15%, aspiration 14%, wheeze 7%, globus, that is feeling of the fullness within the esophagus, that is 4%. So these are in the decreasing order. These symptoms of GERD, that is heartburn, regurgitation, abdominal pain, cough, dysphagia for solids, hoarseness, belchings, aspiration, wheezing, and globus. So this is a Montreal classification of GERD. How the GERD is classified? The GERD is a condition which develops when the reflex of the gastric content causes troublesome symptoms or complications. See, here you can see the esophageal syndromes or extracurricular syndromes. The syndromes is nothing but it's a group of collection of different symptoms as well as entities. So this is, say, as I mentioned, there will be extra esophageal symptoms or extra esophageal symptoms. So coming to the esophageal syndrome, there may be symptomatic syndromes or there may be syndromes with esophageal injury. So what are the, we'll see the symptomatic syndromes. So what are the symptomatic? That is typical reflex syndrome, reflex chest pain syndrome, and coming to the syndromes with esophageal injury, that is reflex esophagitis, reflex stricture, Barrett's esophagus, esophageal adenocarcinoma. And coming to the extra esophageal syndromes, that is established associations and proposed associations. What are these extra established associations? This reflex cough syndrome, reflex laryngitis syndrome, reflex asthma syndrome, reflex dental erosion syndrome. And coming to the proposed associations is pharyngitis, sinusitis, idiopathic pulmonary fibrosis, recurrent otitis. You may not remember all this. So among this entire flowchart, the most important things that is, as an undergraduate you should know is that is regarding that you should know about Barrett esophagus and esophageal adenocarcinoma. So because of this, so why these two entities are important? Because in the long-standing, next in the coming slides I will discussing regarding the complications of GERD. What happens in this GERD means, we in the long-standing cases, that is about 15 to 20 years or later, what happens is because of the reflex contents, these mucosal integrity of the lower esophagus gets damaged or repeatedly gets stimulated because of the action of pepsinogen. What happens? There will be columnar metaplasia. So because of this columnar metaplasia, this lower esophagus damage may convert to Barrett's esophagus. In these long-standing cases, this Barrett's esophagus again, the patient may land into carcinoma, that is esophageal adenocarcinoma. So this esophageal adenocarcinoma is most common in the Western population when compared to our Indian population. So they remember these two things. So in the long-standing cases of GERD, what happens is the immediate complication is this lower esophageal integrity gets damaged. There will be columnar metaplasia, that is conversion. So as we know that the epithelium, this gets into metaplasia this gets converted to columnar metaplasia. This columnar after this conversion in long-standing cases, there this Barrett's esophagus again there will be landing into carcinomatous condition, that is adenocarcinoma. This adenocarcinoma is most common in the Western population. So what are the factors that you should know this slide? What are the factors that can aggravate GERD? So what are the factors? As I mentioned earlier, in case of diet, that is caffeine, fatty or spicy foods, chocolate, coffee, peppermint, citrus, alcohol. So these are the dietary foods that causes the aggravation of GERD. So how the position and activity, how it has an influence on GERD or the reflex means, in case of bending or the straining, what happens is, as I mentioned earlier, say that esophagus and the stomach, they will be having a kinking nature, and this kinking nature, along with this kinking nature, the lower esophageal sphincter and the crux of the diaphragm, they maintain the integrity of this barrier. So if they, in the case of bending position or the straining, what happens is, in case of straining, the abdominal pressure will be increasing. As a result of this abdominal pressure, they will have back pressure. So what happens is that within the stomach, this pressure gets increased. As a result of the increased pressure, and when compared to the esophagus, this pressure is gradually increasing in the stomach. This leads to the opening of the lower esophageal sphincter. This is how this GERD gets aggravated. So how external pressure, the pregnancy, tight clothing, this also may cause GERD. So these are some of the food that may aggravate this GERD condition, or may also may land into the GERD. So coming to the how will we evaluate the case of a GERD? If classic symptoms of heartburn, regurgitation exist in the absence of alarming symptoms, the diagnosis of GERD can be made clinically and the treatment can be initiated. So what are these alarming signs and symptoms? So as I mentioned earlier, see, alarming signs are dysphagia, early satiety, gastrointestinal bleeding, odonophagia, that is painful swallowing, vomiting, weight loss, iron deficiency anemia. These are the alarming signs in case of GERD. Means this patient may be having long standing this until after treatment also it is not responding, and is these symptoms still persisting, these all means they may have some complications. As I mentioned earlier, they may have Barrett's esophagus, or in long-standing cases they may have esophageal adenocarcinoma also. They will be landing develop adenocarcinoma. So what are the diagnostic tests for GERD? So barium swallow, endoscopy, ambulatory pH monitoring, impedance pH monitoring, esophageal panometry. So coming to the first diagnostic step, that is investigation, that barium swallow. So how it is useful in GERD means is the first diagnostic test for patients with dysphagia. So what we will be knowing in the barium swallow means you can see this imaging. So what are these? So you can locate the stricture, or if there is a mass, we can detect it. If the hiatus hernia is present, we may also segregate. We also may classify the size and also the type. So what means what are first coming to the first part, the stricture, how so we can see, we can know the location as well as the length of the stricture. If the mass is present, we can find out the location as well as the length, and the height is and the size and type. So this is the useful nature of barium swallow. So what are the, every investigation we having some limitations. So what are the limitations that are present in barium swallow? So detailed mucosal examination or esogastric esophagus, Barrett's esophagus, we cannot distinguish only in the case of Barrett's in the barium swallow. If we want to know these regarding this esophagitis as well as the Barrett's esophagus, we should either go for the endoscopy or any histopathological examination. So that is a limitation of the barium swallow. So next, coming to the next investigation, that is endoscopy. So what are the indications of, so as soon as the patient comes to the casualty, we'll go for endoscopy? No, definitely not. So endoscopy is an invasive procedure. So initially, so first any patient, if you take any patient, in any case or any disease, what we'll see, what we'll do initially is we'll go for the simple investigations or the basic investigations. With the help of this simple and basic investigations, what will come to the clinical probable diagnosis, and we'll be treating the patient. In this case of GERD also, after clinically, if the patient presenting with the symptoms, if we'll come to the clinical diagnosis by excluding the MI. So as soon as what we'll do is we'll keep the patient on treatment, that is PPS, proton pump inhibitors, or any H2 antagonist. So if the patient failed to respond within after 3 months also, then we'll go for this endoscopy. So that's why I explained earlier. The patient upon treatment also is not responding, then that means this patient may be having any complications or may also further serious conditions like cancers. So in that case, if the patient is not responding to treatment, or their symptoms is getting aggravated day by day, or in this progressing, this complication is getting progress day by day, in that conditions only we will be going to the endoscopy. That's here you can see the indication. That is, if the patient presenting with alarming symptoms or the treatment failure, that is empirical therapy. Next we'll compare, we'll see this therapy. What is the treatment goals of therapy in case of GERD, or in any case of preoperative evaluation or the detection of Barrett's esophagus. See, these are the 4 important indications for endoscopy. So if we ask any patient when we will do endoscopy means, if the patient present in the OPD with symptoms, directly we will not go for endoscopy. These have some indications. In case of any alarming symptoms, or if there is any case of treatment failure, for any preoperative evaluations, what is preoperative evaluation? So if the patient is having any GI bleed means we should be suspecting in the case of any esophageal varices. In that case also we'll go for, we will see how, what are the for the therapeutic purpose also, whether in case of this esophageal varus, is there any chance of any ligating these varices or any for any sclerotherapy, we'll be looking for that. And then also case for detection of any Barrett's esophagus. These are the indications. So coming to the esophago-gastrodiagnoscopy. So when will we perform this? So endoscopy with biopsy if needed, this will go for this. So in patients with alarming signs and symptoms, and those who failed the medication, those who are failed in case of medication trial, and those who require long-term treatment. So any absence of endoscopic features does not exclude a GERD diagnosis. So only allow for detection, stratification, and management of esophageal manifestations or complications of GERD. So next, coming to the important investigation, that is pH. How will you, that is 24-hour pH monitoring. That is, this is a physiological study. So it is one of the useful investigation. Accept the standard for establishing or excluding presence of GERD for those patients who do not have mucosal changes, transnasal catheter or a wireless capsule shaped device. See, What is so main purpose of this pH beam monitoring means, as I mentioned earlier, in the lower esophagus, what happens is normally alkaline nature will be maintained because of the production of salivary gland function, normal functioning. So, but in this case, what happens is because of this reflux of the acid contents, this pH decreases. So, normally in the normal persons, this pH will be in a standard value, standard level. So, but what happens in this case of a GRD patient, this pH keeps on decreasing. So, this is how if you monitor the patient 24 hours when compared to the normal people, these patients will be having a lesser pH when compared to the normal patient. That is how we'll come to the diagnosis in case of GRD patient. So this is see the ambulate 24 pH monitoring. So these will be, if you see in the, on the y-axis and the x-axis, you can see this is the time frame and this is the pH value. So if the day progresses, so you can see this pH will be normal persons. You can see it will be reaching to maximum 2. So, but whereas in the case of GRDPC, clearly this is very self-explanatory slide and it's very important. See, this x-axis is showing the time duration and the y-axis is showing the pH of the fluid content, gastric content. So what happens in the case of normal people, the maximum pH will be 2, that is 2. In a day, if you see here the graph, you can see here the 5 points here, 1, 2, 3, 4, 5, 6. These are the lowest values in a day recorded in a normal person. But when compared to the GRD patients, you can see, in this patient, you can see here less than 1 also, the pH is 0.5. So this is very toxic. In this condition, at this juncture, what happens is if the pH gets decreased, every mucosa will be burnt out. That is, damage will be occurring. So that is the main pathology involving in this GRD. Because of the decreased pH, here the pepsin and pepsinogen acts on the mucosa and it completely damages it. So that's why the patient will be having this heartburns, or any regression symptoms like dysphagia, odinophagia, everything, vomiting nature, nausea, everything. So this is very important slide. That is ambulatory 24-hour pH monitoring. So now coming to the main another important investigation, the esophageal manometry. That is, this shows the pressure. As I told earlier, because this lower esophageal sphincter gets relaxed, there will be pressure differences within the gastric as well as the esophagus. So how will we assessing the pressure within the esophagus and gastric? This is the main role of esophageal manometry. Assess lower esophageal pressure, location and relaxation, and assist placement of 24-hour pH catheter. This esophageal manometry is mainly directly assisting the 24-hour pH monitor. So it assesses peristalsis and prior to anti-reflux strategy. So now coming to the, so we have discussed the definition of GRD, the pathophysiology of GRD, and the types of GRD, the clinical manifestations of GRD, and the investigations. And the last part one, that is the treatment part. So how will you manage? This is very important. So ultimate main aim is to treat the patient. How will we treat the patient? So there are some goals for the treatment. That is the goals for therapy. So we should get the first symptomatic relief, and we should heal the esophagitis. So what happens if the esophagitis is not healed? As mentioned, the patient may land into Barrett's esophagitis, and further Barrett's esophagitis may be converted into adenocarcinoma. That is why it is very important. And to prevent and treat the complications and maintain remission means the patient should not get after 3 months. He should not be complaining, sir, again our the symptoms were activated, and again I am getting the similar symptoms as I experienced 3 months ago. So coming to the first part, that is like first important part in the management, that is lifestyle modifications. So that is how can lifestyle modifications prevent GRDs? That is weight reduction if overweight. So how weight reduction has a role in preventing? So as I mentioned, if in case of fatty persons, this integrity, what are the esophagus and the integrity may not be maintained. In that cases also there will be regurgitation. So avoid clothing that is tight around the waist, and modified diet. So we should eat more frequent but smaller meals. Why? So what is the how it is helpful? So what happens? In the case of generally we will be taking breakfast at around 8 o'clock, and again we will be taking lunch around 1 o'clock or something. So what happens in between is whatever food we take in the early breakfast, this gets digested slowly, and there will be gastric emptying slowly. So when the stomach is empty or in the fasting, that is what happens. These HCl production gets activated, and this more HCl is produced. So because of this more acid content production, if normal in case of normal people, they will be seeing some burn within the heart. Will be feeling that burning sensation in the stomach. That is nothing but the excess gastric HCl production. So if it consumes some food or any solid food at the time, what happens is this production gets decreased. As a result, that pain will not be seen, or it get decreased. That is why we should have more frequent meals. Means that ultimate goal is, if you're having more frequent meals, there is decreased production of gastric HCl. The decreased production of gastric HCl, the mucosal integrity will be maintained normally, and this patient may not develop any GERD symptoms. So then we should avoid fatty and fried foods, peppermint, chocolate, alcohol, carbonated beverages, coffee and tea, onion and garlics, and we should stop smoking and elevate head of bed for 4 to 6 inches. Why? As I mentioned in supine position, what happens? These regurgitate contents are very easy for them to pass into the trachea. So avoid eating within 2 hours of bedtime. So coming to the treatment when proper, that is pharmacotherapy of the GERD. So first mainly treatment, the antacids. So what is its use? It's quick but short-lived relief and neutralize the HCl acid production. And approximately 1/3 of the patient with heartburn related symptoms you use at least twice. You should use this patient at least for twice weekly, and more effective than placebo and release GERD symptoms. So antacids is first one of the treatment. And next line treatment, that is histamine H2 receptor antagonist. So it is more effective than placebo and antacids for relieving heartburn in patients with GERD, faster healing of erosive gastroesophagitis when compared with placebo, and can use regularly or on demand. So see, what are these H2 receptors? Some of the examples are cimetidine, famotidine, ranitidine, and nifedipine. Just you know, you may not know doses. You don't remember the doses right now. Just name just try to know the examples. Some of the examples of H2 receptor antagonists are cimetidine, famotidine, ranitidine, nifedipine. Cimetidine is 400 to 800 milligrams twice daily. That is 2 times a day. Famotidine is 20 to 40 milligrams twice daily. Ranitidine, we will be using this drug very frequently. In our case, because of the cost effective nature, we will be using this ranitidine is 150 milligram twice daily. So next one of this pro-candidates. So how it is a role in preventing the GERD or decreasing symptoms means promote gastric emptying and reduce risk of gastric acid reflux. And the main drugs nowadays, we are using these drugs as the mainline treatment for the GERD. Remember this, proton pump inhibitors. So what is this proton pump inhibitors? So in the drug name itself, it uses self-explanatory. Proton pump inhibitors means protons means H plus. H plus means hydrogen ions. These are hydrogen ions. That is the main role of pH. If this H plus ions gets increased, this pH gets decreased. So if we inhibit these proton pumps, then the HCl production will be decreased. So further damage does not occur. So better control of symptoms with PPS, and better emission rates, and faster healing of erosive esophagitis with PPS. So here you can see some of the examples of the PPS, that is esomeprazole, omeprazole, lansoprazole, pantoprazole, rabeprazole. So among these, this is the rabeprazole is a long acting actually, but generally we will be using in our general OPD case we will be using the omeprazole and pantoprazole. So because of the cost effective nature. So remember, everything is cost effective in India. What we have to focus means everything is cost and benefit ratios. We'll see everything. What is the cost? What is the benefit? Similarly, it's also cost effective treatment only we will be giving to the patient. So see here, esomeprazole, the dose is 40 milligrams daily, generally 20 to 40. But omeprazole is 20 milligram per daily, lansoprazole 30 mg daily, pantoprazole 40 mg daily, rabeprazole 20 mg. So this everything should be taken in empty stomach. Why it is empty stomach? Because in empty stomach only there will be excess gastric acid production. That is HCl. So protons will be produced in the fasting condition only. There will be excess production. So that is why we'll be prescribing the patient that is you should take the tablet on the empty stomach. So on empty stomach, this prevents the excess production of HCl. That is the main reason why we are saying the patient you should be taking an empty stomach. What happens, as I mentioned, if you take after the food consumption, definitely the production will decrease, and the absorption of the drug also does not occur properly. So when comparing the both H2 receptor antagonists and proton pump inhibitors, there will be 12-week freedom from symptoms. Means these patients after three months, what if you ask the patients, 48% of patients who are taking H2 receptor antagonists are saying that we have got relieved from the symptoms. But in the case of population, if the 100 patients are taking, see, this is 48% means 100 patients who are on H2 receptor antagonist. Among them, 48 people are saying that we got relief from the symptoms. If we take another subset of population with GERD, if we prescribe them with PP proton pump inhibitors, 77% of the people, that is 77 out of 100 people, are saying that we got relief from symptoms. Means by this you can understand that proton pump inhibitors are more efficacy, have more efficacy, and also the better treatment than historeceptor antagonists. So now coming to the healing rate, that is esophagitis. Whatever in this case 52%, and in case of proton pump inhibitors 84%. So and coming to the speed of healing, 6% per week and 12%. See by this slide is very important. Why I have kept this slide? Means see, by this we can come to the conclusion that proton pump inhibitors are far more efficacious than historeceptor antagonists. So coming to the effectiveness of medical therapies for GERD treatment. So as I discussed earlier, from the treatment part, that is lifestyle modifications initially, then the pharmacotherapy, that is first like antacids, followed by historeceptor antagonists, and followed by PPRs. So among these, if we take a predominance levels are in the response, if we consider the response levels, so how these are useful. See, lifestyle modifications and antacids, 20% of the GERD patients get relief. If you use historeceptor antagonists along with the lifestyle modifications, 50% of the people are showing the better results. So if patient is only using without any lifestyle modification, only using proton pump inhibitors, 80% of people getting remitted. Means they are becoming free from the symptoms. So if you increase the dose of PPA, 100% of the people are become normal. So that's the importance of this proton pump inhibitor. That is why I'm stressing this. These proton pump inhibitors are the mainstay treatment of GERD. If the patient is not responding to proton pump inhibitors after 3 months of trial also, then we have to go for endoscopy. That is the next line treatment. So after you giving the patient may not get relieved within 1 or 2 days. Definitely it will take time. So the time period is generally we will see for around 3 months. After we will wait for the 3 months for this. So in the case of if any, there is pharmacotherapy gets failed, or if the patient is not responsive, so next line modality of treatment is surgical treatment, that is anti-reflux surgery. So when it is indicated in case of failed medical management, patient preference, GERD complications, medical complications attributable to a large hiatal hernia, atypical symptoms with reflux documented on 24-hour pH monitoring. So remember these indications. So when we have to go for surgery, so what are the indications? So if the patient is taking a 3 months trial of any proton pump inhibitors, in spite of this patient is not getting any relief from the symptoms, in that person, what happens? So he may also be why I'm using all this medication. Better I go for any surgery so I get relief from the symptoms lifelong. You will be thinking like that. So in that case, there is any failed medical management, patient preferences, GID complications. As I mentioned, the patient will be having some repeated aspiration pneumonia. In long-standard cases, they may be having chronic bronchitis, everything. So to prevent that complications, also some of the patients may prefer for the surgeries. So medical complications are attributed to large hiatus hernia. So if there is hiatus hernia, if you're keep on giving proton pump inhibitors also, the patient may not respond. So in that case, that surgery is the mainstay of treatment. If we get relief from the hiatus hernia, the symptoms almost they get subsided. So atypical symptoms with reflux documented at 24-hour pH monitoring. These are the indications for surgical management. So anti-reflux surgery candidates. Proven as esophagitis on gastroduodenoscopy. If the patient is having having esophagitis, normal esophageal motility, partial or complete response to acid suppression. So these are the principles of anti-reflux surgery. So what happens after the surgery is the main aim of us to restore the intra-abdominal esophagus, appropriate the diaphragmatic crura, and reduce the hiatus hernia and perform fundoplication. These are it's in order. It is in the sequence. See? So first, what will in case of hiatus hernia, there is a herniation of the gastric part of the stomach wall. This should be brought to the normal texture, and then immediately we have to approximate the diaphragmatic crura, and this we should restore the intra-abdominal esophagus, and finally we should fundoplication. So this is a procedure that is Nissan's laparoscopic fundoplication. Nowadays, laparoscopic is the main advanced treatment. See, you can see here. This is fundoplication. So you can see here. This is fundoplication. So this is the partial versus complete versus partial fundoplication. See here the partial application. So how will we see? So post surgery, some of the people may having some symptoms as well as some post surgical complications like excess bleeding, hemorrhage, everything will be there. But post surgery, some of the symptoms, how will we treat? 10% have solid foot dysphagia. So post surgery, if you take people, they will be having 10 among them. 10% may have solid foot dysphagia, and 2 to 3% have permanent symptoms, and 7. So no surgery is 100%. Remember that no surgery is 100%. There will be no guarantee. So 2 to 3% may have permanent symptoms, and 7 to 10% may have gas, bloating, diarrhea, nausea, early satiety, like. So coming to the endoscopic treatment, relatively new, no definite indications. Select well, informed patients with well-documented GRD response to PPI therapy may benefit. Three categories, that is radio frequency application to increase lower esophageal reflux barrier, endoscopic sewing devices, injection of a non-reabsorbable polymer into LES area. So coming to the complications, as mentioned, so this is the final part of this topic today for talk, that is complications. So what are the complications of GID? As I mentioned earlier, erosive esophagitis is the first complication. If they keep on, so what happens is inflammation keeps on damaging the mucosa. So further, because of the damage, the necrosed part will become fibrosis, and fibrosis further leading to stricture. So the next immediate complication is stricture. So because of this nature, this repetitive damaging, so the patient may undergo columnar metaplasia, and there resulting into Barrett's esophagus, and the long-standing Barrett's esophagus again converts into adenocarcinoma. So see here, erosive esophagus responsible for 40 to 60% of GERD symptoms, and severity of symptoms often fail to match severity of erosive esophagitis. And this stricture, result of healing of erosive esophagitis may need dilation. So what is the stricture means? It gets this esophagus gets narrowed. So because there is narrowed, if you consume food, the patient may be complaining of dysphagia initially. Then again, because of this, after the food entering over the here, this proximal region of the stricture, this part gets dilated, and this patient complains of odonophagia, that is painful swallowing. Here there will be painful swallowing as well as dysphagia. So initially the patient may complains initial for the first two, you'll be having some normal. After consumption 2 to 3 food, what happens is this patient starts complaining of dysphagia and endophagia. So what is the main ultimate treatment in this case of stricture patient? That is dilation. So CSC, balloon dilatation of peptic stricture, transthoracic. So next complication, Barrett's esophagus, that is columnar metaplasia of the esophagus associated with the development of adenocarcinoma. So here we can see the Barrett's esophagus. So acid damages lining of the esophagus and cause chronic esophagitis, and damaged area heals in a metaplastic process, and abnormal columnar cells replace columnar squamous cells. So what is this columnar metaplasia means? Here the damaged area heals in a metaplastic process, and abnormal columnar cells replace the squamous cells. So normally the esophageal lining is lined by squamous cells. In case of Barrett's esophagus, these squamous cells which are normal, these gets replaced by the abnormal, that is columnar cell. This is called as columnar metaplasia. This is the pathology in the Barrett's esophagus. It is an important part of the pathology you will be learning. So this is columnar metaplasia. This specialized intestinal metaplasia can progress to dysplasia and leads to adenocarcinoma. This is the final long-standing complication. So manage in similar manner that we will be giving a proton pump inwards and esophageal gastro every 3 years in patient without dysplasia. So why this will be every 3 years will be performing esophageal gastro duodenoscopy means to see whether these changes may leading to adenocarcinoma. So for that purpose we are seeing it for every 3 years. In patients with dysplasia, annual to shorter interval surveillance. So this is to summarize the first, we have discussed about the definition of GRD, and coming to the epidemiology. So definition means that is troublesome symptoms. Patient is having any troublesome symptoms. That is the definition. Epidemiology means the most common in the 6th decade. That is mostly fatty people. That is in the case of Western, obese, and white people. That is most common in this. This is the regarding epidemiology. And pathophysiology is main assessment. Lower esophageal sphincter and the crust of the diaphragm. This maintains integrity. If there is any damage to the integrity or also the lower esophageal sphincter relaxation, this GRD develops. So what are the clinical manifestations? First main clinical manifestation is heartburn, dysphagia, odinophagia, chest discomfort, everything. And next one, the final one is, see, coming next to the diagnostic evaluation, how will we evaluate this? 24-hour pH monitoring and endoscopy, gastroduodenoscopy, everything. Among that, the first line is the most important thing is 24-hour pH monitoring. But generally, we will not be. So clinically, we will evaluate the case and we will keep the patient on treatment. Now, coming next to the treatment part, the patient antacids, proton pump inhibitors, H2 receptor antagonists, and lifestyle modification. Among these, proton pump inhibitors are the mainstay of treatment. So next coming to the complication, that is erosive gastritis, strictures, and the next one is the Barrett's esophagus and endocarcinoma. So remember this side it is. If you remember like this in order, it will be easy for you to write in the examination. So why I have stressed regarding everything in this GID is because it is an important 4 marks question. Not only 4 marks question, which is also very important for you after the completion of the MBBS also. It's very important. This GID you should know in detail regarding how this patient manifests, how this patient presents to the OPD, and how to manage the case. Very important. That's it. So as an undergraduate, you should know the definition of GID. Coming to the pathophysiology, you should know. You should know the clinical manifestations. You should know investigations, treatment. Not in detail, like everything you should know. Just in general, like basic things you should know. As I mentioned, as I briefly explained on the final part of the summary, you should know this all this briefly. Definition, epidemiology, pathophysiology, clinical manifestation, diagnostic evaluation, treatment, and complications. So, thank you.